Hi, everyone, and welcome to the Clinics Review Articles podcast series. I'm Taylor Hayes, the managing editor for Facial Plastic Surgery Clinics here at Elsevier. Facial Plastic Surgery Clinics is a quarterly publication that provides clinical and scientific aspects of the latest cosmetic and reconstruction techniques and materials. Joining me today are guest editors of the November 2025 issue, Dr. Sydney Butts and Dr. Adam Johnson. Welcome to the podcast.
I'm Dr. Anthony Sclafani. As consulting editor of Facial Plastic Surgery Clinics, it's my distinct pleasure to welcome Dr. Sydney Butts and Dr. Adam Johnson to the conversation. Doctors Butts and Johnson have assembled an excellent issue on lip, palate, and facial clefts. Dr. Butts is the interim chair and professor of facial plastic and reconstructive surgery and otolaryngology at SUNY Downstate Health Sciences University. Dr. Johnson is an associate professor of pediatric otolaryngology from the University of Arkansas. Thank you and welcome.
Do you mind introducing yourselves and giving us an overview of the chapters in this issue and why you decided to include them?
I'm Sydney Butts, a facial plastic surgeon, the interim chair of the Department of Otolaryngology at SUNY Downstate, and the chief of facial plastic surgery at University Hospital Downstate, and also at our sister hospital, Kings County Hospital Center. It's a real pleasure to be a co-editor of this volume on lip, palate, and facial clefts. I think what's really rewarding about being a part of a project like this is the ability to highlight the great work that friends and colleagues from around the country are doing for these very deserving patients through all spectrums of their lives, from infancy through adulthood. We have designed the articles to mirror the lifespan of a patient born with a cleft. So we start with articles about prenatal diagnosis and end with articles about how to address persistent functional and aesthetic issues in patients with clefts who are now adult. So most of these articles are written by friends, right, who I've gotten to know over years of collaborating and being an admirer of their work and getting to know them at scientific meetings. And in fact, the way that I first met Dr. Johnson, who's the co-editor of this issue, was at a cleft meeting that was started by several of our colleagues, both of whom are in the issue, so Travis Tollefson and Krishna Patel. And we had about every 2-year VPI meeting that first started at Vanderbilt and then moved to Charleston at MUSC, where Dr. Patel is a faculty member. And I think I first met Dr. Johnson at one of those meetings. We were both presenting along with other faculty members. And, you know, the quality of the presentations was so incredible. And I remember listening to Dr. Johnson's talks and already seeing how skilled and talented he was as a cleft surgeon. And so, you know, you get to know people and follow their work. And so for me, it was a no-brainer to hope that he would want to collaborate on this. And so when he said yes, I was really happy. He is a pediatric otolaryngologist. I'm a facial plastic surgeon. And, you know, within otolaryngology, these are the two specialties most likely to take care of patients with clefts. So I think we bring our perspectives from these two different subspecialties, and that makes it a really well-rounded issue.
Yes, I do remember meeting Dr. Butts at that meeting. That was 8 or 9 years ago. And since then, I do appreciate you really helping me with my career, inviting me on things like this. And I will say, when Dr. Butts asked me to do something, I almost always say yes. And the fact that she was asking me to work on her on this cleft cleft edition, that was an easy no-brainer. The thing that I hold near and dear to my heart, cleft, and then working with Dr. Butts, those are the two things that just makes life easy. But myself, I'm Adam Johnson. I am at the University of Arkansas for medical sciences. I'm a pediatric otolaryngologist and the program director for UAMS, and I also work at Arkansas Children's Hospital. I'm a cleft surgeon. I do a lot of plastic type surgeries, rhinoplasties, things like that. So taking care of cleft children from birth until old age, and we're able to do that at our hospital, which is fantastic. This special edition is just really exciting. Again, working with all of our friends, but really just it's interesting because all of our friends are kind of the next latest and greatest of the up and coming, basically cleft world when it comes to surgery and comprehensive care. The authors that are in this special edition are all just amazing folks who have done great things. Isama Handan, who runs a Global Smile Foundation, which is a group that does outreach basically year round and has just tons of expertise. They've been doing that for 30 to 40 years now. And so a lot of the expertise that comes from doing these medical mission outreach programs, you can see that in the chapters, and it's just amazing stuff. And so I'm really excited about this going out there. It's comprehensive, it's state of the art, and I'm just really excited about it.
Thanks so much. And thank you both for agreeing to work on this issue together. It's going to make a great addition to the facial plastic surgery clinic series here at Elsevier. Jumping right into our conversation today, I wanted to ask, how can facial plastic surgeons collaborate with geneticists and maternal fetal specialists to optimize early surgical planning for cleft lip and palate cases identified prenatally?
There's a chapter in the issue on prenatal diagnosis and then familial counseling to talk to parents who have received the diagnosis of a cleft lip on a prenatal sono. So because the technology for prenatal ultrasound is so advanced now, as early as the second trimester, 3D or 2D ultrasound can diagnose a cleft lip. The sensitivity of diagnosing cleft palate on ultrasound is still not as good, but there are other types of imaging, such as fetal MRI, which can also pick this up, especially in a patient that's a little bit more high risk. So that chapter was co-authored by Dr. Johnson and myself and our colleagues at Tufts, including Andrew Scott, who's a pediatric otolaryngologist there, who does incredible work on cleft and craniofacial surgery. So more and more referrals of children with clefts don't happen from the NICU when the child is born. More and more are happening because of the ultrasound diagnosis. But the issue is that if you get that diagnosis when you're 22 weeks pregnant, you still have another trimester and a half perhaps to go before your child is born. And in that time, there's an opportunity to really talk to parents about what to expect to ease their anxiety. And so, geneticists are certainly a part of that because the family may opt to undergo an amniocentesis to look for certain, genetic abnormalities or try to diagnose syndromes. But so the answer to the question is there are numerous opportunities to work with geneticists who often play an important role in the multidisciplinary cleft and craniofacial team, through the patient's life, but especially their early life.
Yeah, I agree, Dr. Butts. And the way we use geneticists in our own practice is we really collaborate with them early on, especially for that counseling piece. A lot of families will blame themselves and things like that. And having that geneticist there, not only for me to give kind of the emotional side of it, of not placing blame and pointing fingers, but allowing them to have a really strong scientific piece to show that like this is not your fault. This is something that we can handle and we'll get through. Early counseling is just so important, just to manage expectations and to get everybody on the same page. And so having that genetic counselor there with you is really helpful.
Thanks so much for sharing. On to the next question. So when syndromic clefting is present, how do genetic findings influence your surgical timing, technique selection, and long-term reconstructive roadmap?
It allows us to prognosticate better and plan more specifically. So for instance, if we know that a patient has a 22q11 deletion syndrome, also known as velocardiofacial syndrome, sometimes termed DeGeorge syndrome based on the child's phenotype, then we know, for instance, that they may have a greater chance of having velopharyngeal insufficiency even after the cleft has been repaired. And that has to do with the fact that they often have muscle tone issues. So even if you've done an excellent repair, you've done a furlough, you've lengthened the palate, there may still be some underlying intrinsic issues related to the syndrome that will affect the speech outcomes. And so that's helpful in talking to families and setting the expectations that there may be additional surgery down the road to make their speech normal. There are other findings that go along with that syndrome, for instance, that you can really talk to parents about in terms of long-term outcomes, other symptoms that need to be managed by other specialists. So I think that's just one example of ways that, because we know so much more about the disease, we know about the variable expressivity of it, that helps us have early conversations and plug patients into the types of services that they need. And there are several academic medical centers that have specific VCSF centers where they gather a group of people who've taken care of these patients for a long time and have experience in really guiding them through the disease process. So that's one example I can think of.
I'd like to just add that while I agree with Dr. Butts wholeheartedly on those very specific situations, a lot of times we do get this diagnosis. And the one thing I'll say is, the question asked about technique changes. In all honesty, the technique, and I don't know, I don't change my technique really for any of these situations. It's always the same kind of precise and very just methodical care that we do as far as the surgical techniques and things like that. It would be rare for me to change something unless there was a very specific reason for it. And I do agree with the timing with SARS-22Q deletion, basically VPI. You do want to wait a little bit longer in those kids to allow them to develop as far as correcting the VPI surgically. And then also counsel a little bit more, again, prognosticating, like Dr. Butts said, letting parents know that usually our outcomes are not as good right off the bat when we correct the VPI.
On to our next question. So, which pre-surgical interventions have you found the most effective in improving symmetry and reducing tension during primary repair?
I love NAM, nasal-alveolar molding. I think it's fantastic. I'm not always in a situation where I have access to that, but if I can have it, I love it because the nose for me in a cleft lip is the most challenging part. And so getting symmetry of the lip, I think I can get pretty close to perfect on that. Getting symmetry of the nose in a cleft lip repair, I find to be much more difficult. And so nasal-alveolar molding, and we have a fantastic chapter on these pre-surgical orthotics and taping and all these sorts of things, I feel like is fantastic when performed correctly by a certified person who knows what they're doing, can really set your surgery up for success to the point where you are correcting something with basically minimal stretch, minimal need for movement, minimal tension, because things have been moved already into the right place. The hardest thing that I find is turning that nostril, basically the alar portion where it's flat or inverted, and trying to make that a curved segment. That is one of the most difficult things to do. But if you have nasal-alveolar molding and you have already curved that for you and basically made that inflection point, it makes it a lot easier to make a nice rounded nostril that looks much more symmetric, creating those axes in the same plane.
No, I agree. I think several of the modifications to lip surgery that, the foundation of which, of course, is the Millard repair, but people have modified that to deal with and address some of the sequelae that come with the incision designs. And Something that I've seen, which NAM and other types of pre-surgical procedures really help avoid, is making an incision around the ala of the nostril on the side of the cleft that needs to be advanced. And when that happens, that scar tissue can cause a scarring and block to the blood supply to the nostril that actually causes it to it's a negative effect on growth. And so these patients can then go on to develop like a micronostril. They have difficulty breathing and there's asymmetry. So when you're able to mold the nostril and the lip elements and the alveolar elements beforehand, you don't need to rely on these more extensive incisions to move the tissue together. So I think that's really another way that nasoalveolar molding and taping and nostril elevators have really helped the functional and aesthetic outcomes for patients. We have two articles in the issue on pre-surgical approaches. One that focuses on NAM by Dr. Ahmed and her team from Montefiore Albert Einstein, which is incredible. It's so detailed. I really hope everyone gets a chance to look at that. And then another article from the cleft and craniofacial team at SUNY Upstate in Syracuse that focused on lip taping, nostril elements, and also a history of pre-surgical molding techniques, including pre-surgical orthopedics like the Latham Millard device that was introduced several decades ago to give people an overview of how these techniques have evolved. But I agree, it really does help with symmetry and setting the foundation for lip reconstruction later on. And if you are at a place where you don't have access to NAM or the patients can't come in weekly because it can be demanding, we wanted to make sure we had information in the chapters about other types of techniques that can help with symmetry if NAM is not a possibility.
What are the key anatomical and technical considerations that differentiate unilateral from bilateral cleft lip repair? And how do you tailor your approach to optimize aesthetic and functional outcomes?
I think the authors of these chapters say this very eloquently, that a bilateral cleft is not just two unilateral clefts. It's a much more complicated anomaly because of the congenital absence of muscle in the prolabium, which is the central part of the lip that makes up the philtrum and the central part of Cupid's bow. So, there's no muscle there. It takes a lot more manipulating to reconstruct the oral sphincter. And because the premaxilla is in isolation centrally, what can happen sometimes is that the premaxilla, which bears the incisor teeth, can protrude significantly in front of the lateral alveolar segments. And that is something that will need to be addressed, which is different than in a unilateral cleft. So again, we were just talking about nasoalveolar molding. I think if you have that ability, it's a tremendous help for patients with bilateral clefts to get the alveolar ridges aligned with the premaxillary segment makes a huge difference in the ability to restore the anatomical relationships.
Yeah, I agree with you. Absolutely, Dr. Butts. Really, just that premaxillary segment in a bilateral, you've got to control that kind of right off the bat. Otherwise, it can really protrude. And I've seen some serious complications from other places, usually some outreach things that the premaxilla can actually push its way through the lip if you don't control that. And not having access to NAM, there's no reason not to tape or something of the sort in order to control that segment, and just very different than in your unilateral, where you still need to control both segments, but not nearly as severely as you do in the bilateral.
In adult patients seeking revision surgery, what are the most common aesthetic concerns you encounter, and how do you balance structural correction with patient expectations shaped by years of lived experience?
I'll say that the patients that come in as adults who have continued functional and aesthetic issues, be they continued speech problems, scars from the lip repair, functional or aesthetic nasal issues related to nasal obstruction. They're hopeful conversations, but as you said, Taylor, they can be tough conversations because these are a group of patients who have been through a lot in their lives, and they've had numerous surgeries, they've had multiple encounters with the healthcare system. Many hopefully that have been positive, but as a young person to have to go through serious surgery, long hospitalizations, it can be, patients are left with tremendous anxiety. And when you meet them as adults and you talk to them about additional surgery, it can sometimes be a little bit of a hard sell. So I think initially what's required is really developing trust in a relationship with the patient before going down the road of a laundry list of what they need. And the other thing I didn't even mention were dental and occlusal issues that many of these patients have. Many of them may not get regular dental care. Some of them may need restoration. Some of them haven't had complete restoration. And so there may be numerous additional procedures they need. I've sometimes made the mistake of feeling like being very hopeful and saying to patients, well, we can do this and we can do this. And I think you have to meet patients where they are, and understand that what you want for them, they may not be ready for that. But I think for the adult patients, many of them are coming to us for, at least to me, for rhinoplasty consultation and functional breathing problems. So that's where we start the conversation, just talking to them about what their, how seriously the nasal obstruction affects their quality of life, and sitting down with them, taking pictures, talking to them about where the asymmetries are and how we can try to correct some of these issues and the surgical plan.
Yeah, so one of the articles we have actually is on basically revision surgery. And there aren't great scales and things that are out there that kind of give us a graded type of situation so we can actually grade how we're going to establish our revision and what we're going to do. And that's the thing that I love about the revision article, is it actually gives us a nice scale based on severity, based on skin, and then what you would do about it. And I love that chapter because it's a lot of photos of adult patients that are coming back. And, the thing that we always think about is that, we start kind of working on these patients as children, and then lifestyles change throughout all of that. People pick up good habits, people pick up bad habits, and so you always have to kind of take all of that stuff into account. And one of the options that that chapter gives us is talking about using local anesthetic for some of these kind of minor revisions that you can do. And I think that provides a great option for some of the patients, especially some of our older patients who maybe have some other comorbidities and things like that that would not be great for anesthesia. And so having that option is really nice. I've used a couple of these techniques for local anesthesia, and I think that's a really good way to go if you have that option. And then I agree with Dr. Butts, is it really set expectations. These patients have been whittled away on a lot of times multiple surgeries, multiple different surgeons. You don't want to be the person who is also the whittler. So you just want to make sure that what you're doing is in the patient's best interest at that point, and that they understand the risk and benefits of the entire procedure that you're proposing to them, or not proposing, and where it can go from there.
Yeah, thanks for pointing out the importance of patient-centered care and, setting expectations prior to these revisions. To wrap things up today, is there anything else you wanted to add? And is there anything that you can share about what the future looks like?
I'll just add one other point about the adult patient. We have another article in the issue by Dr. Amelia Drake from the University of North Carolina and her team. And one of the reasons we were so excited to include her as an author is because aside from having a tremendous leadership in cleft care, she was the president of the American Cleft Palate Craniofacial Association and has been a mentor to many in otolaryngology who do cleft work. But she saw this group of patients who had had surgery perhaps in other places, maybe now living in North Carolina, and established a care team and an approach specifically focusing on adult patients and what the issues they contend with are, which I think is so sensitive, but also such an incredibly smart way to, again, gather the care team. As Dr. Johnson said, where a lot of the focus of care for these patients is early on in life. The first, particularly intensive surgeries, the first 5 to 6 years of life, and the dental care that they get. And then the care and the surgery get spaced out further until they reach skeletal maturity. They have, orthognathic surgery. We have a fantastic article on that and the issue as well. And then after they reach 18 or 19, the regular visits to the cleft team may not happen as routinely. So I think Dr. Drake saw there were opportunities to continue to allow older patients whose care might have been sporadic to be able to connect with the healthcare teams of people who have expertise in this work, but also bring in another group of surgeons who spend more time working with adult patients. So I wanted to highlight that because I think we feel this is a really important article that's in the issue. I think for me, what's really exciting about cleft care in the future is people that are doing basic science research and understanding some of the more of the genetic underpinnings of these diseases. Most of the patients that have clefts, we diagnose them as isolated, right? Because we just haven't figured out what the gene is that has caused their orofacial cleft. But there are people who are doing more of this work, helping us to understand more of the influences on how these conditions develop. I know one of the authors in the issue, Steve Gowdy at Emory, who wrote the article on genetics and syndromes, has spent years studying some of the genes that are related to clefting. And so to me, that's where more and more work is continuing to happen and hopefully getting support. So I think that's important for us to continue to understand more. So I think that's a great future. And then I think in learning and teaching of cleft care, this surgery, it's very meticulous, it's very detailed, and the first time is the best time, right? So you want to do everything that you can at the first stages of repair to make sure that you're setting the patient up for the next stage. So more and more surgeons are embracing the idea of simulation in teaching cleft surgery to fellows and residents. One of our authors, Dr. Krishna Patel, who's a co-author on the chapter on unilateral cleft repair, has really championed simulation and has used simulation models at numerous of our scientific meetings to help teach cleft lip. So I think that's another exciting area, is how we make learning of these procedures easier and more straightforward for trainees.
I definitely, again, piggyback on that, Dr. Butts. For me, when you say, the first surgery should be the best surgery, and I agree with that wholeheartedly. In fact, I think that's really kind of the future, is better outcomes with fewer surgeries is really what we want to look at. And with the kind of now proposition of doing primary rhinoplasty during the cleft lip repair, that's starting to make some headway, and people are starting to research and figure out if that's even feasible, and will that affect our outcomes. And the hard part with cleft surgery is you don't know your true outcomes until your patient's almost an adult. And so that makes it really difficult. But I think we've started to see, especially looking at some of our rhinoplasty cases in having to do early surgeries because of traumas and things like that. We're starting to see that we can do some of these things a little bit earlier to kind of help affect the nose instead of waiting until adulthood or just about adulthood or when we start to correct basically the nasal portion of everything. This special edition definitely just kind of highlights a lot of the future aspects. And I agree that the future is also very molecular and genetic of how we deal with these sorts of issues.
Doctors Butts and Johnson, thank you very much. I'm sure our listeners are excited to read the new issue, and I appreciate the work you and your authors put into creating such a fine piece of work.
Thanks so much for taking the time to speak with us today, and thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on lip, palate, and facial clefts, visit us.elsevierhealth.com/expert. Facial Plastic Surgery Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to subscribe to the Clinics Review Articles podcast wherever you get your podcasts, and thanks for listening.